session. Let's hop into the first session now. So the theme together is working, the theme here is working together, how cities and hospitals and CBOs are partnering to reach more people and make programs work better on the ground. Equitable access is central to Maryland's population health strategy. This discussion will explore how data and workforce initiatives and local partnerships can ensure every Marylander has access to quality care and support. So help me welcome on the stage Zachary Rabovsky, Director of Population Health and Strategy and Practice Transformation at CareFirst. We have Dr. Letitia Dzirasa, the Deputy Mayor, Health and Human Services for the City of Baltimore. You can come on up, don't worry about it. We have Temi Oshiyoye, Director of Community Health Improvement at Luminis Health, and Carmella Watkins, Executive Director, Ivy and Pearls of Southern Maryland Community Charities.
All right, are we mic'd up here? Yep. I'm on, good. Well, this is an exciting morning. Thank you everyone for coming out. We're hopefully going to provide for you guys an exciting conversation really about partnership, how we are all coming together here in the state of Maryland to close the access and equity gap, what we're doing that's so great that makes Maryland special and unique, but also what we still have left to do. Quick introduction. My name is Zach Rabovsky. I work at CareFirst, BlueCross, BlueShield, and CareFirst is one of the nation's largest not-for-profit healthcare organizations. We serve 3.5 million members, and we have a network of 1.7 million providers. And our mission is access and affordability. And specifically what I do in that realm is value-based care implementation. I am the Director of Practice Transformation and Population Health Strategy, and we work with our providers, our health systems, as well as our governments and community-based organizations to drive that mission. And I'm excited to talk with our panelists today and hear about how we're all partnering together. So what I'll do is I'll ask our panel to start with a brief introduction, and then we'll get into some questions.
Okay. Well, good morning, everyone. My name is Letitia Dzirasa, and I am the Deputy Mayor of Health and Human Services for Baltimore City. But I served as the Health Commissioner for Baltimore City during the pandemic. So from 2019 to 2023, was Health Commissioner and then transitioned into this role. So I have a very unique perspective, having worked on that side and now working in the Mayor's office, where I oversee and support about 6 agencies in the Health and Human Services realm. So I'm still supporting the Health Department. I also support our Office of Homeless Services. We have an Office of Children and Families. We also have an Office of Older Adult Affairs and Advocacy. I support Recreation and Parks. And then we have a newly created Office of Overdose Response for Baltimore City. And so a lot of what I do, as we've kind of heard, sits at the intersection of how do we integrate public health and equity with serving some of our most vulnerable population in Baltimore City. And again, coming from the Health Department, I have this perspective of taking a public health and equitable lens to all the work we're doing across our Health and Human Services agency. So really excited to be up here and get this conversation going.
I am Carmella Watkins with Ivy and Pearls of Southern Maryland Community Charities.
There we go.
Good morning. I'm Carmella Watkins with Ivy and Pearls of Southern Maryland Community Charities. And I represent the rural perspective because we are in the country. But we try to make a difference. And we have 167 volunteers. And so we are able to get out into the community and do a lot of things that other organizations might not be able to do because we are trusted. We are people who go to church with the groups that we're trying to reach. Our children go to school with their children. And so it's pretty easy for us to be trusted in the community. And so Ivy and Pearls of Southern Maryland Community Charities has been organized for 10 years. And we work very closely with Nu Zeta Omega chapter of Alpha Kappa Alpha sorority. And so we have, and our Nu Zeta Omega has been in existence for 40 years. And for a long time, we were the only Greek letter organization in the Southern Maryland area. So we have it forced us to partner with a lot of organizations that you probably wouldn't see a Greek letter organization partner with, like the NAACP and the health department. We reach out to the school system. We work very closely with the school system at times. So we have really tried to make an impact. Thank you.
Good morning, everyone. My name is Temi Oshiyoye. I'm the Director for Community Health Improvement at Luminis Health. Luminis Health is a health system that entails 2 hospitals in Prince George's County and in Anne Arundel County. And we have 100 sites for primary care and specialty care in both counties, as well as on the Eastern Shore. In my role as the Community Health Improvement Director, I focus a lot on community health initiatives within the community. Partnership is very, very big. How we can work with other partners within the community to address the same goal that we have. Addressing equity through preventative services. We do a lot of screenings within the community, and we focus a lot on chronic disease. We focus a lot on diabetes, heart disease, as well as a focus on maternal health as well.
Wonderful. So we've got up on this stage today, provider, payer, government, community-based organization. So a lot of different perspectives. So we're going to get into some questions that we've prepared for the group. But I also want you guys to think about questions for yourself. We may have some time at the end for Q&A. So we'd be happy to take some questions at the end as well. But the title of this discussion today is From Data to Action. So let's start off by a question for the entire panel. How are your organizations today currently using data to make decisions and to target disparities when looking to close the access and disparities gap?
Well, we try to evaluate every event that we host, and then we look at those evaluations to try to figure out what it is that we need to do better. So we have QR codes. We've got a great technology group within our organization. And not that I am that technologically savvy, but they are. Our young people are very technologically savvy. And so they've got QR codes on the tables for every event. They've got, everything so that we can evaluate what we do. So I appreciate that. I may not be able to do it, but I can certainly look and see what it is that we need to do better.
And what are some of the insights that maybe you guys have been able to pick up with that new technology that in the past maybe took longer to collect?
Well, that's one thing. It's faster, because before we were using paper, and now we can collect that information instantly and be able to examine it right away and make changes right away. So it doesn't take us as long.
Yeah. Dr. Dzirasa, how about you?
Sure. So I think, the city has access to a lot of data. And I think our charge is to use it in a meaningful way, right? And so, and it's both qualitative and quantitative, right? So you've got all the data that's coming in, maybe it's death data from the state, but then you've also got, constituents who are emailing you with their concerns. And so one of the things that I think that we've done well is utilizing something called City Stat. And so as a city, we're looking across agencies and we stat out certain performance measures, right? And so for the health department, it could be related to infant mortality and disparities that we see there. For rec and parks, it could be related to the safety of our park system. It really just depends. But when we have those city stats, we really are trying to bring in, multiple agencies so that it's very much a cross-agency approach. But we also have a neighborhood sub-cabinet where we bring in community leaders to get that additional data directly from the community. And then I think as we're getting the data, we're talking to community-based organizations. We're leveraging the existing relationships that they have across the city to move the needle and to get the work done. So it doesn't just fall on government, though we often have access to a lot of the data.
Fantastic. Yeah.
Yeah, from a hospital perspective, we're looking at multiple forms of data. So we're looking at the data that we're collecting within our own hospital system, the data that we're collecting in our primary care sites, but we're also utilizing community data. So we utilize a lot like the community needs assessments. We utilize that data. And we're looking at all that data. One, the use of that technology helps with predictive analysis. So we're looking at the data. We can pretty much predict almost hospital readmissions, and then really look at it case by case, the patient itself, how can we prevent that hospital readmission? And what that also does is it really does help with that care coordination across multiple disciplinary teams to get involved in patient care, but also it leads to development of different initiatives. So this is some of the needs that we're looking at within the community. How do we address this as a system? Because at the end of the day, we're still going to see those patients. They might be in the community now, but at the end of the day, we're still going to see them in our hospital. So what are the initiatives that we can develop based on the data that we're seeing that we can address that need?
Yeah, and that's a very real connection when you have a patient sitting in front of you and they need support to prevent a readmission or to follow up from an admission. So when you have that data and you have that opportunity, what are some of the connections that you make in the community as a provider to help bridge that gap and to get the patient the services or the support that they need?
Yeah, so it really just depends. And I'm going to answer that question in two different ways.
Yeah.
So if it's more of a medical thing, let's say the person has very high blood pressure and for some reason they keep coming back because it's very high, or maybe it's diabetes related, then we're doing remote patient monitoring and we're utilizing that system. So maybe their blood pressure is connected to our system where we're asking them to take their blood pressure every morning. And then we're getting their primary care office is getting the blood pressure reading. And then we're basing interventions based on that. The other piece is looking at what is driving it. And that's when we get into the social drivers of health. And we utilize that. And if anyone has ever been a Luminis Health patient, it doesn't matter how many times you come to the hospital, you'll fill that form every single time. You'll fill that form every single time. But what we're looking at is what are those other factors? So are we looking at housing? Are we looking at transportation? Are we looking at other factors? Issue with paying for a pharmacy. Maybe that's why they're not being compliant with their medication. They can't afford it. It's too expensive. And that's when we then connect them to services within the community that can help drive that. So there are different ways that we look at that data and then we find solutions to it.
Wonderful. Yeah. So let's talk about those partnerships because I think it's kind of come up at a high level, but are there any, an open question again to the panel, specific partnerships that you're proud of recently that have really kind of supported in terms of patient outcomes? And then also in a follow-up to that, where do we still need partnerships that we don't have today?
Sure, maybe I'll kick us off. And again, my view is a little bit broader, right? So I house and support the Office of Overdose Response. And so Baltimore City received a little over $500 million to really address the opioid crisis. And that requires multiple agencies participating, but specifically our Office of Overdose Response is responsible for providing grant funding to community-based organizations. And so one that I'm really proud of is we're supporting a group called Impact, or Maryland Peer Advisory Council. And these are individuals with lived experience who essentially are peer navigators for individuals living with substance use disorder. And so as a part of that partnership, they will help us maintain naloxone kits in all the MTA stations across Baltimore City. And so there's this, public-private partnership with the state who runs MTA, the city, and then also this community-based organization who's going to help maintain those boxes and be directly in the communities that we're serving. And so while when we're looking at kind of numbers and impact, it's a little bit harder to get a tangible impact, but clearly the impact that we'll have having naloxone at every public transit system in Baltimore City, I think is immeasurable.
And everyone has to play a role in that, right? In order for that to be successful.
Absolutely.
So where do we still need partnerships? What's kind of the next step?
Yeah, I mean, I think what I hear, and I'm sure we have some community-based organizations in the room, it's still challenging for kind of operational infrastructure support for CBOs, and that's not always something we traditionally grant out. And so I think if we could somehow figure out how to support our CBOs in developing their operational infrastructure and helping them tell their story with the data, then I think we'd see even more partnerships form, right? We'd have the city and the state even more excited about working with CBOs. And so I think there's still a lot more room. I think we just have to figure out how to connect those dots.
Sounds easy, right? But of course, there are those challenges there. Carmella, how about you from the CBO perspective? What are some of the partnerships that you rely on that have been successful, and where do we go next from here?
Okay, so we work very closely with the Charles County Department of Health. We have many programs with them. We work with smoking cessation. We work with heart health. We have been working with them for a while, and it's been pretty successful, I would say. And it's been helpful to them because we can get to those places that they can't. And we can work with those people that they might not be able to reach. And then we have a very successful partnership with Lifestyles because we are trying to provide SNAP benefits, get people signed up for SNAP benefits. And what you don't understand is there's when people are hungry, they aren't going to be healthy. So that's something that we really want to push. We want people to be healthy. We got to feed them. And so we're trying to work with any organization that we can. Now, where we are lacking is faith-based organizations. We need to work more closely with them. We got to pull them out because they tend to not want to work with everybody, you know? So but we can get to them because we worship in these places. We know the people. We are part of their community. So that's something that we need to really, I think, work on.
Absolutely. That's a great perspective there. And Temi, from a provider perspective, you know, there are hundreds of physicians and providers at Luminis that are delivering care, and certainly they need to rely on partnerships in order to get their patients the care that they need. They can't do it themselves. So how does Luminis support their provider organization with partnerships and help them connect the dots?
So we see our partnership as everyone and anyone could be a potential partner. And the reason we look at it that way is because everyone and anyone can be our patient. So everyone is our provider. I mean, everyone is our partner. So we work with different providers, from schools to recreation centers to non-for-profit organizations to religious groups. We work a lot with a lot of our churches in both of our counties. And I'll give you a good example of a collaboration that we had with one of our churches during COVID. And this is a mega church in Prince George's County. It's called Reed Temple, if anyone knows the church. And we worked with them during COVID to really get the message out. Because it is a mega church, they had a wide audience. I think their church sits about like 10,000 people. So they had the audience that we need. And this was during the time where there were so many messages about COVID and the vaccine. And we really wanted to get the right message out. And we knew that in order to get the message out, we needed trusted individuals that the community will trust, and we needed to work with them. So our partnership with them was very, very strategic because we wanted them to get the message out. We didn't want them to see a white coat saying you should get the vaccine. We wanted them to see their pastor. We wanted them to see people that they go to school together, that they go to the people that they really do trust. And that partnership, we were able to vaccinate over 30,000 people in our community just through that partnership. So for us, partnership is very, very important and very, very strategic because, like I said, everyone is our patient. So we have to work with everyone.
Absolutely, absolutely. Okay, so I'm going to offer maybe a moment of vulnerability here because I didn't hear anyone say partner with the payer. So I'll give you a chance because I know the partnership's happening, but I'll give you guys a chance to maybe share with me how we can partner together as well and what that partnership might look like in a system where everyone's kind of working together.
Yeah, I actually will speak to that. And
Great.
so I didn't mention it, but one of the longstanding initiatives at the Baltimore City Health Department, Be More for Healthy Babies, was funded in large part by CareFirst. CareFirst was a very long time funder of that work, which really worked hard alongside. We have a partner in the audience, Baltimore Healthy Start, to decrease infant mortality and the disparities in that infant mortality gap between Black and white infants across Baltimore City. So I think that was a great example of how we work with CareFirst. But I think my future vision of how we can continue to work with CareFirst is really around collaboration with the data, right? And so CareFirst, largest payer here in Maryland, you all have access to this claims data that I think is so critical if we're able to combine it with some of the city data around what we're seeing as it relates to social drivers of health. I mean, something like, could we have something where we're looking at vacants across Baltimore City, and then putting on top of that the aggregate, healthcare data for that region. So I think there are lots of opportunities.
Yeah, and actually one of the ways we're supporting providers right now with data is by providing them with social risk indicators at a member level. So we are actually now able to take our social risk scores and attach that to attribution in our value-based programs and go to a ACO or go to a provider and say, this is what your population looks like. Not the population around your office or in the neighborhood surrounding them, but the patients that you're treating. And it's very eye-opening. Often, we hear so many times from providers, I don't have any disparities in my practice. And, you roll your eyes, and then we show them the data, and it's very much evident. But a wonderful way to partner. From the CBO perspective, Carmella, what are your thoughts on how we could partner together?
Well, we partnered with Aetna already. They have sponsored our some activities for our young people. They have provided packets for the young ladies, period packets for the young ladies. They have sponsored one of our debutante ball. I mean, they have really stepped up and supported us. Where I see we need more. That's pretty much it.
Yep.
We need more money. Because you can't run these programs on wishes. So you need money, you need funding, and it costs. So I mean, if you want to work with young people, and we do, and if you are worried about babies, if you don't want our kids to smoke, period. You don't want them to smoke. You have to have programs. You have to allow them, you have to educate them about why they shouldn't do these things. And and so you need models to demonstrate those efforts. It costs. That's all.
From a larger Luminis perspective, I know there's been multiple collaborations that's been between Luminis and CareFirst and other payers, but I'll speak specifically with what's been going on within my department and within community health. We are on some conversations with United Healthcare, with what you just spoke about in terms of really looking at patients that are under their provider and really just addressing social drivers of health and looking at that as well. Aetna has been a sponsor in the past of our community baby shower. So we have an annual community baby shower where we provide resources to new and expecting mothers within the community. And they have sponsored a couple of things from strollers to diapers to car seats and things like that. With CareFirst, we've also worked within the space of maternal health. Throughout last year, we've had a couple of collaborations together, and then we are in the works of another collaboration that is on maternal health. Maternal health is a very big focus for Luminis Health, especially in Prince George's County, where 8 out of 10 mothers leave the county to have a baby outside of the county. And I know that's what the data says, but I think it's higher. That's just my perspective. So let's go with the 8 out of 10. But I think it's higher because I live in Prince George's County and I do not know a mother that's had a baby in Prince George's County. I have 3. I had all 3 outside of the county. So maternal health focus is very, very huge for Luminis Health in Prince George's County. And we are in the communications with CareFirst to do a preconception.
Yeah, we have a great partnership there. But one of our other partnerships is on the value-based care side, right? So maybe speak a little bit to how this work with community-based organizations and getting patients the support that they need in the community kind of fits into the Luminis VBC strategy.
Yeah, I mean, I think a lot of that work tends with the work that has been done, especially around the social drivers of health, looking at what are the resources that our patients needs and how we can address those resources. When we look at that, even just the value-based contracting, for us, about 80% of our patients are part of that value-based contracting, which at the end of the day is, the ROI looks better, but also we're, improving health outcomes, we're really saving on readmissions, and we're addressing the care right where they need it. So even, based on that conversation and just that partnership alone really does impact our patient care and how their outcomes look as well.
Mhm, absolutely. And we do a lot of work with our providers as well, trying to connect them with community-based organizations, making sure that they know what's out there. We don't necessarily think it's the provider's job to, solve for hunger or transportation barriers, but you have to know about that as part of a treatment plan. In this day and age, it's like a new medication or a new procedure. You got to learn, you got to understand. So we do work with them to help them out, and being able to connect those dots is incredibly important, and will hopefully lead to savings and ROI on the VBC side. I want to shift just slightly because everyone here has brought up trust and the importance of trust. And I think individually, you've been able to maybe build trust with your stakeholders, but maybe this question to start for Dr. Dzirasa: how do we build trust at a system level? How do we kind of take the lessons learned from what Carmella has done in many CBOs to build trust in the community where people eat, sleep, pray, and bring that back out at the system level and kind of earn that trust that we're all in this together?
Yeah, I think that's a great question, and certainly a charge that we held during the pandemic, right? And I think something that was unique about the pandemic, for better or for worse, it did feel like at the time we all were unified around a common goal. And so I think that helped us in some ways because we kind of had to work together, hospital systems, health departments, community-based organizations, in order to accomplish our goals around certainly reducing disease burden. And then the next goal was also making sure that we got as many folks vaccinated as possible. And what I heard often, especially from our community-based organizations and from our partners that were working directly with community, was that trust was built through consistency. And so many of our communities, really were very honest. We think that when this pandemic is over, you all will leave. As a health department, as a city government, you all will no longer be here. And so I think the thing that we've had to do is remain consistent in our presence, to show the community that we are still here, remain consistent in our partnerships, so that we can continue to work, with health systems, and with CBOs, who are often the ones on the ground. So I'm going to point to just like consistency and presence.
Yeah, wonderful. Carmella, how about from your perspective, any tips or anything you hear from your community members that we can all take back to earn trust?
Well, I think it goes back to when you had programs or activities and they were not, and the health community was not looking out for African Americans, and they were doing testing on them, and they, and it wasn't to their benefit, it was to the organization's benefit, but not to the individual's benefit. And I think you still have that now, where people just don't trust health organizations. They're kind of leery. And so we still have to get over that. You have to get the people to understand that it's for their benefit. And any tests that they do, that they take a part of, it's for the benefit of everyone and not anything that's detrimental to them. So that's the way you have to build that trust. You have to get them to understand that it's for the benefit of everyone, and it's not going to be detrimental to their own personal health.
Sure. Temi, have a take on this one?
Yeah, I mean, I think with partnerships, you want to start with that grassroots, getting involved as much as possible. But the other important piece is also being able to listen. Going into the community, don't expect that you know the answer and you're coming with, you guys have a problem, I'm just going to help you fix it. No, you want to listen to what is going on, listen to their concerns, listen to what their perceived, things that are factors that are influencing it, and not really come from a solution kind of, but listen to what is going on. And, the grassroots efforts that have been going on, what are some of the things that they've been working on? So not just with a mindset of we're going to fix it, we have the money to fix it, we know what to do, but just really listening and understanding what's going on. And like you mentioned also as well, being present there and the consistency. So it's not a one and done. like we fixed you guys, we're moving somewhere. No, 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 no. It doesn't work that way. It's the consistency. You keep the relationship going on.
The easiest way to break trust is to not be consistent.
Yes.
Yes, we say it all the time. Wonderful. So I think that would be a great time maybe for us to pause. I have tons of questions, we could keep going, but I wonder if the audience has any questions they'd like to ask of us, and we can maybe take some time for Q&A. And do we have a mic, by the way, that we can pass around?
Thank you. I know when you start talking about being able to have these partnerships, many organizations and agencies are looking at including people with lived experience. And I think when we talk about CBOs, because we are actually using and valuing the expertise of people with lived experience, how can the partnerships work to value the experience of community-based organizations? And I understand being able to provide some funding for special events and all of that. Those are the ones that you could tap into and do that. But to really value the experience of the people that you need at the table, how do we raise this to that level that payers actually start to see the value in the people that we serve, and not, I don't want to sound negative, not give the little trickle down dollars that happen to come at a certain time.
So I feel like that's probably a question for me to start off with, and then yeah, yeah. I mean, I think it's a really important area, right? And something that we have to discuss. Right now we're kind of in this midst of a lot of changes in the way healthcare is financed and funded, right? And I think that there's a future for more dollars being funded towards community-based organizations for these types of partnerships. We've done a lot at CareFirst already to invest in community-based organizations, providing grants, listening to those that have a proven track record, being out in the community. We have a fantastic community health and social impact team and community engagement team that is listening to the voices of not just the members that we're serving, but also all of those that are living in the jurisdictions that we serve, whether or not you're a CareFirst member or not. And from a value perspective, being able to kind of take those voices and use that to help improve access to equitable, affordable care will always be our mission. And so we're going to set up those value-based programs. We're going to set up those payment models. We're going to surround our network around those institutions to be able to give our members and those peoples in the community what they need to live a healthy, well life. Any other perspectives or takes on how we maximize the voices of those that we're representing?
I think in just
Maybe pass the mic.
Thank you. I think just in community engagement, and just going back to what I said with listening. So hospitals, in all hospitals, are required to have a community health needs assessment. And in order to do that, it's a collaboration between the hospital, the health department, and all the community-based organizations within that county to come together and put together a need of what's going on within the community. And I think those are some of the ways where we have multiple voices at the table and seeing things, because the community-based organizations are going to see things that the hospital is not going to see, and same with the health department. And then all those voices coming together and say, this is what we're seeing that is going on within our community. I think with that itself really showcases, as a collective voice, we're speaking of what our need is in the community. And then that drives initiatives, that drives collaborations of working together, either through grant opportunities or, or just a contract or something like that. Then that drives that as well.
Great question. Other questions? We have a few up here in the front.
Thank you, dear. Thank you very much. My name is Layla Riazi. I'm here under a couple of hats. One with my colleague, or we say partner in crime, Diane. and also Carter in the community. We are leaders in individual villages to help older adults, we say in Cheverly, to stay in community and age in motion, or to be able to age well in community. I'm also president of the Washington Area Villages Exchange, working with over 80 villages across Maryland, DC, Virginia, West Virginia, and parts of Pennsylvania. And what I'd really like to ask of you is both the instances in where you have seen the opportunity to work with these largely volunteer-based communities to make sure that you're honoring that we are part of the continuum of care for the people that you're working with. Also, to help grow the village movement. Because when older adults are able to maintain agency and decision-making in how they wish to age, how they're able to stay in their homes as long as their health supports, and the idea that not only benefits those older adults, but absolutely benefits all of our communities, that is absolutely essential to all of us aging well, staying healthy, wealthy, and wise in community. And I'm happy to talk further, but I'd like to see what your experiences have been in your roles. Thank you.
Sure, maybe I'll get started. And again, I'll maybe point a little bit to the pandemic and some of the work that the health department did. So recognizing that our older adults were particularly vulnerable, and recognizing that we wanted them to also be able to age in place, we focused on how we could work with community-based organizations and our hospital partners to vaccinate older adults where they lived, right? And so to make it so that they didn't have to worry about transportation or mobility, but we actually set up a time to go into senior apartments and with our healthcare partners and set up a time to come back. This is when we had to give that second dose. And it was so well received. Obviously, they appreciated us coming into their home. Additionally, we provided senior meal delivery boxes, and we're still doing that work. The mayor actually recently announced additional funding in light of when we thought SNAP benefits were going away, to provide additional home meal delivery boxes. So there's one box that's coming out of the health department that is shelf-stable food, and then another box that's coming from our Department of Planning that is fresh fruits and vegetables. And so I think, to your point, we want to support our older adults to age in place with dignity, but to also have the resources that they need to be well and healthy.
We work with, have partnered with the Alzheimer's Association. We support their walk every year. And we work with Morningside, a community, senior community, and we do activities with them. We always have, annually, we have a day with them, and we'll support them in any way that we can. But we recognize that all of the things that you said, that it's important for seniors to be able to age in place and age the way that they would like.
From Luminis, we have a partnership with our Department of Aging in our counties. And what we've done through that partnership is do screenings at home. So we have a mobile van that we can take out into the community and we screen. We'll do blood pressure, cholesterol, we do A1C as well as glucose. And then we take those screening results if need be, and then we're helping them to connect back to their primary care provider if needed. And if not, it's, you're kind of good where you are, kind of in information, but it's really just helping them, with the aging in place, dealing with the transportation issues that they might have and going back and forth to primary care providers. And we're doing those screenings at home in both of our counties.
All right, I think we have time for one more quick question.
All right, hi. I'm Angela Martin with Maryland Community Action Partnership. We represent the state's 17 community action agencies who are federally and state designated anti-poverty agencies for the state of Maryland. And one thing that we are seeing is the well-being of the frontliners, right? Those who are on the front lines providing the services. We're seeing their well-being and their health and mental health being challenged, burnout, stress. You know, we're seeing an increased number that they are having to serve due to, you know, economic distress and the social and economic distress we're seeing right now, right? And so my question is to CareFirst and Luminis, right? Have you, or this may be something you're already doing, so please let me know, but are there programs out there that really address the staff of these agencies? Do we have promotions? Do we have different programs that would promote that well-being for frontline staff, for community-based organizations? Yes, we do appreciate the dollars for our conferences and for events, but in addition to that, what is needed is to really enhance services for those who are on the front lines. And so are there programs out there? If not, I've got some ideas I'm happy to share.
Absolutely. Why don't you start?
I'll start with our Luminis employees. So for our Luminis employees, there are programs that we have within Luminis Health to deal with burnout, mental health challenges, just, stress related to work. If there are any nurses or doctors in the room, I'm sure they can speak better to it than I can. So there are programs that we have within Luminis Health to help our employees to deal with that. We also have a virtual urgent care that is called Care Connect Now, where you can call in and pretty much it started out as a kind of primary care need program is what it started out. And then during the pandemic, it really did morph into having providers to address stress and mental health challenges and things like that. So that is something that is available beyond Luminis, actually, because it is widely available on our website. There is a number to call. Actually, the number is on my phone too, so I can share that with anyone that needs it, but you can also Google it too as well. It's called Care Connect Now. And it's an opportunity for anyone to utilize it as well, because we do understand that there is a lot going on right now, and there's a lot of burnout, a lot of stress, a lot of mental health challenges as well.
And from our perspective, just quickly, we certainly invest a lot on the wellness side and behavioral health support. But externally to CareFirst, we've also recently started a community workforce development program with Coppin State and the Urban Center for Families, and we are helping to develop careers for new frontline workers and increase the number going into this field. And we hope to see that maybe take some of the stress off of those who feel that they have to or have been doing it alone. But wonderful question, and we could talk for a long time about this, and would love to hear your ideas afterwards. So let's talk. That's it for us here this morning. Thank you guys. We've reached our time. Really appreciate it, Dr. Dzirasa, Carmella, Temi. Really appreciate your takes. We hope this was an informative discussion, and we look forward to meeting and chatting with everyone later today. Thank you guys.